I think I still believe in that when God is kind on you, everybody becomes kind on you. So that is what it is. Anyway, I will get on with this. May I just understand that that we all are talking about stereotactic body radiotherapy for prostate cancers today, right? And yes, it is primarily a target delineation talk, but I will be trying to touch on many aspects, and feel free to pitch in if you guys think that something is not required, or something is way out of line, or something like that. I will try to put in the British perspective here, with a bit of an American flavor as well, or so-called tadka, whatever. And I'll try to make sure that I'll make some sense of this. So please forgive me if there is anything which I cannot explain, but I'll see how it goes. Right? Thank you. So should we begin?
Dr. Kamal, yes.
Yeah, please. Okay, fine. So I'm just thinking that my screen hopefully is fully visible here.
Yeah, fully visible. You are audible. Everything
Okay.
is visible.
Okay, excellent. So hello everybody, and we are just getting on with things. These are some of the disclosures, and I don't think they are very much relevant for this talk. However, this is how I want to do it today. We will touch on some objectives at what I'm planning to achieve with this talk. We will go to a bit of a background of prostate saber. So again, SBRT or SABR is kind of going to be used interchangeably for the purpose of this talk, wherein stereotactic body radiotherapy stands for SBRT, and stereotactic ablative body radiation stands for SABR. In England, we like the SABR word more, but the English are English, can't help it. So then we'll touch upon some of the pre-planning aspects of SBRT. We will then delve into the core specifics of the planning bit, and some of the post-planning areas of this talk. Okay. So here it is. This is kind of what I am thinking we might be able to achieve with this talk today. I want to go through and summarize and discuss the clinical issues involved, and with all the SBRT, including the target volume delineation, the contouring aspects. I'll touch upon some tips which I give to my team here in terms of planning, etc. And we will go to those prescription strategies and plan evaluation sets as well. I would like to go to other things as well, but I think let's walk first before we fly, and see how we get on with this bit of the talk. Okay, so this is one of my first key slides. And again, in this world of evidence-based medicine, we always want to know why we are thinking about SBRT. And in this, I hope that this is all visible to you. I've tried to summarize all the key papers in SBRT of the prostate. And as you can see, as is my when I'm moving the mouse, is my mouse movement visible to all of you?
Yeah, it is visible.
Oh, excellent. So for example, you will see we are talking about the schedule here, and the number of patients, what category, the risk class. So L stands for low, I for intermediate, and H for high risk. We will touch upon these things as well. Then the follow-up period, late toxicity, and failure-free biochemical survival. So that is also there. You can see that people have used quite a varied dose range and fractionation range here. But as mentioned in the introduction, we are trying to exploit the alpha-beta ratio and the radiobiology here of the prostate cancer. and that's where it comes into. My understanding is that a lot of audience today is likely to take their boards or likely to take their MD examination or similar postgraduate examination in radiotherapy within a span of 1 to 3 years. Am I correct?
Yeah, you are correct. But many of us are consultant also. Maybe
Okay.
they are doing IGRT, means long fractionation of a prostate, and now planning for SBRT prostate.
Okay, good. So yeah, so that's fine. I think SBRT is going to come in big time pretty soon for everybody, and whether in the exams for the juniors or whether for practical usage for the consultants, it is all going to be very useful. So here is the basis for this, and you can go through. I've put in the details of the paper as well there, from where we get. These are a bit of the acronyms. So I'm talking of stereotactic body radiotherapy, and this is delivered via the daily online image guided radiotherapy. That's IGRT. And forgive me if there is a bit of a repetition here and there, but I will try to do that just in case we do not miss out on anything. So we are talking about various delivery techniques like VMAT, helical tomotherapy, robotic gantry or MR-Linac, and we'll be all of that will be referred to under the SBRT or incorporated within SBRT for the purpose of this talk. With VMAT, I'm of course referring to volumetric modulated arc therapy. Okay, so coming to this, again, from the key planning bits, I believe that that's one of the ways I see SABR in a beam's eye view. So whether it's isocentric or not, what are the beam arrangements, and what is the PTV dose distribution is going to be like. So as you all know, isocentric or not, like for example, if it's Linac gantry based, we are talking about isocentric treatment, but CyberKnife, we are talking about non-isocentric treatment. In beam arrangements, we have coplanar or non-coplanar beams, and like static gantry angle IMRT can be thought about versus the VMAT technique. And in the PTV dose distribution, you can have an alternate, like a simultaneous or alternative boost. Just this is to give an idea about the particularly more for the juniors, that how we are thinking about the isocentric and non-isocentric. What is the machine system like? So thanks to Accuray and Brain Lab, who have allowed me to use these some of these pictures. Okay. Now, for a glance, this could be a very short summary of the CyberKnife plan. So here we are thinking about typical treatments consisting of about 100 to 120 non-coplanar beams. We have a treatment time of nearly an hour. However, imaging correction every 5 to 7 beams, so about every 30 to 90 seconds. So quite an intensive plan. CyberKnife plans can be. Here I would quickly pitch in with a note about VMAT. So here we have volumetric arc, which simultaneously changes. Gantry rotation speed is thought about, treatment aperture shape, MLCs, delivery dose rate. We are keen to improve dose conformity, and the aim is fast plan delivery with VMAT. Again, just a quick cartoon about the Linac IMRT and VMAT plan, just very quickly to have a look of how we would, one of our patients, how would that look in the look at completion. Coming to fiducials, may I just ask the consultant audience, where are we with fiducials and the planning of this in your centers? Are you guys using fiducials a lot?
With SBRT prostate, actually, I in my center not doing SBRT prostate.
Okay.
And in other regions, we are putting fiducials. Dr.
Okay.
Arun, you can comment. Dr. Veed is also there.
Actually, there is a variability in the practice across
Yeah.
India. There are people who believe in putting fiducials, and there are people who do not believe in putting fiducials. So there is a lot of variation.
Okay. Brilliant.
Yeah.
So I'm glad that I've catered to all kinds of audience then, because yes, even in England we have a varied practice, yeah, and even in the States, there some people believe that fiducial markers are very useful, some don't. What I would like to say that in England we are very sure of at least one thing, that if you are using MR-Linac guided radiotherapy planning purpose, you do not need fiducial markers. You can very safely exclude fiducial usage. But even in CT plan things, some people don't use it. I have no particular reservations. However, it is just to put a note out there, because ideally, fiducial markers implanted are usually very helpful for image guidance, and here we have to ensure that the planning studies are recommended at least 7 days after fiducial placement to avoid any artifacts. Now, for the fiducials, particularly for the people who are very, very keen to know the details about it, I will very quickly whiz through this busy slide. I've purposefully dimmed the slide because I was not hoping to get into a massive detail about it. Essentially, they should be visible, of course. At least 3 markers are usually good. Antibiotic cover has to be thought about as per the local policy, and we have to ensure that the imaging, when that is done, is your imaging levels must be at least 2 centimeter or more. They are normally done as an outpatient procedure here, and 1 to 3 fiducials are fine. Maximum 4 in total are fine for CyberKnife SBRT. This is just to give you an idea about how it looks like, how you've placed your fiducials, and how brilliant you are in your artistic talent when you are doing your radiotherapy planning. I've always believed that radiotherapy is a lot to do with art as well, apart from science. And so one of my very senior professors taught me that your plan should look beautiful, uh, as well as it should be good. So anyway, this is just a image to explain to you guys how would our fiducials look like, and that is fine. Now we are coming to the planning scans. A lot of people may know about this, but I would like to reiterate these things from the SBRT purpose. We here in England, I like to do the CT slices 1 to 1.5 millimeters for SBRT. We know that up to 3 millimeters can be allowed for conventional IMRT. For CyberKnife, the scans will extend at least 15 centimeters above and below the level of prostate. That is our standard, and we have followed that in our various trials as well. And the purpose of this 15 centimeter or the 15 centimeter rule is that here we are including the testes so that these can be used as a blocking structure. And this point is particularly useful for the people going for exams, and because very likely you will be asked about SBRT, whether you take your MD exams or DNB exams in India, doesn't matter. You need to know to what extent you want to do your planning scan, because if you do not get that right, you are not getting to a good plan. Then thinking about the gantry-braced SBRT and MRT, these should extend from L3 to L4 intervertebral space to 2 centimeters below the ischial tuberosities. I'm being so specific here because it's better to be specific and get things right than to be not specific and just allow people to do their own thing. I am particularly very, very respectful and very trusting of our radiographers. But remember, with SBRT, it's a big game. Your stakes are high. Per fraction dose is very high. So you really need to be very, very sure when you are doing everything right from scratch, that everything is happening perfectly. So this is my stipulation for these scans. So L3 to L4 intervertebral space to 2 centimeter below the ischial tuberosities for sure. then planning MRI scans needed to determine. Yeah, we know that MRI has always helped us with the better delineation of the anatomical borders of the prostate and, if possible, the urethra. Again, I particularly am a big fan of fusing the MRI and the planning CTs. I think I've found that extremely useful. It depends on the planning system you're using, but I think that is going to be very useful from the planning perspective when you are doing the delineation later. Just as a check, uh, uh, is my pace all right? Am I audible okay? And should I carry on?
Yeah, so your pace is all right and you can carry on.
Okay, good. So for anybody who is joining in now or who has been delayed in joining in, don't worry, I have not come to the meat of it yet. So so you can still open your eyes and open your ears, because we are now coming to the core bit of my talk swiftly. Again, for any radiotherapy treatment, we are thinking about bowel prep, bladder prep, immobilization. I'm not specifically going into the super duper detail of this because this is very specific and individualized for your centers. I'm sure you will have a plan for your bowel prep, your bladder prep, immobilization. We have ours, so you can just follow any of that. I'll just put in a quick note about the rectal spacers. This is so I think the papers go back to nearly 8 to 10 years when rectal spacer, hydrogel, or rectal balloons were talked about. And in I think in 2014, the National Institute of Clinical Excellence, that is the NICE in England, approved their usage in England. Of course, they're pretty expensive, but they're not. It is not NHS England funded at the moment. But I think in India, with the kind of private sector taking a big leap forward in radiotherapy planning, this can be used. So this is a hydrogel, which is, as you can see, rectum, the prostate, and you're putting a hydrogel there. So all you're doing is a very smart way of putting the rectum behind. And this gives you space between your prostate and rectum. And this is not rocket science for anybody in radiotherapy, that the more space you have between the treated structure and between the organ at risk, the lesser is going to be your toxicity. So whether or not a lot of people have used this in their clinical trials or not, don't worry about it. If you can do it, if your patients can afford it, get somebody to put a rectal hydrogel, and this is going to bring you favors. It is not going to bring you pains at all. So you can easily see that your high dose is not even touching the rectum. And that's how you are going to hugely reduce the rectum toxicities. So that is one of my first few key take-home messages, that if you guys can use that, if you can arrange this for your patients, definitely try that. It works. Okay, so we'll touch on now the target volumes, delineation, and as I said, the meat of the talk. First things first. Again, here, whenever we are talking of definitions and delineations, the way I see it is that when you're using MRI fusion images for voluming, these tend to be, less consistent, more superiorly, particularly at the level of seminal vesicles. We know that. Just be aware of that. Therefore, I would always recommend, whenever you are trying to define or delineate, use MRI fusion for voluming the prostate and rectum interface. And wherever there is a discrepancy, get out, take your CT anatomy book out, and you will be able to see. I'm pretty keen on my trainees and my colleagues to always have a radiological CT anatomy book with them. It has saved a lot of grief for all of us to have that radiological CT anatomy book in our planning rooms. I am a bit old school in many ways. This is one of them. but it has always helped me. And all of the structures should be outlined on CT anyway. Cool. So we are now touching on the, I'm just trying to re-emphasize that why MR planning, we think that it is that bad, but when your fiducials are in, when you are already doing your MR planning scans, you have correlated that and brought the CD with the MR, you can have that that accuracy of delineation. Before we give a plunge into the very core specifics, this slide, you may agree or disagree or have your views about it. So I think we all know, and I'm sure the consultants in this group today will agree that stick to at least one risk categorization of prostate cancer. Am I correct in that, gentlemen and ladies?
Yeah, you are right.
Yeah. Pick anything. Take whatever classification, but pick anything. I have chosen the National Comprehensive Cancer Network risk categorization for my patients. So far, it's worked all right. It is not ideal, but then you can choose your ideal. So here we have the low risk, T1, C2, TA, Gleason score less than or equal to 6, and PSA less than 10. So remember, there is an and here. That means all of these criteria are to be met for a cancer to be called low risk. Whereas the moment we turn away from the low risk, in the intermediate, you have a T2BC or a Gleason 7 or 10 to 20, whatever, even one of them, all right, is enough to call it intermediate. Then you have the high risk, the T3As, the Gleason's 8 to 10s, or PSA more than 20. Any one of them could lead to high risk. Of course, then there is a very high, and people will talk about the low intermediate and high intermediate as well. But clearly, I would call this as high, this is intermediate, and this is low. Now that is going to be helpful to us in contouring. Okay, so we will start with CTV, the clinical target volume. For all the juniors, it is imperative that you know the book definition of CTV. What is CTV? So this is your first homework. Whether you take much from my talk or not, but as juniors, you really need to be very crisp with your understanding, your practical understanding of CTVs, PTVs, and all these target volumes. So in the prostate cancer SBRT setting, which I'm going to talk about, the CTV should include the whole of the prostate with and without the proximal seminal vesicles. We'll call that PSV. And the inclusion of SVs within the treatment volume differs, and that is something which I can't help because everybody has their own views about this. But you'll find that some studies will include the prostate alone, and others include some or all, generally the proximal half or proximal 1 to 2 centimeters of the seminal vesicles. We know that from the pathological studies that it is reasonable to omit the SVs in low-risk patients. Some people do that, some people don't. And just include the proximal 1 to 2 centimeters in the intermediate and high-risk patients, respectively. We'll come to that again. Now, PACE trial, this trial is something which you can always look up. Now, Dr. Google tells you everything. You can look up. So PACE is one of the key trials. There are 3 phases of this trial: PACE A, PACE B, and PACE C. And this is a British trial where this is a trial of SBRT in various formats. It's not a bad idea to look at this trial. They've tried to bring it all together, and I've taken quite a lot from the PACE trial because we were participants in the PACE trial for prostate SBRT. So the CTV for the low-risk patients in the PACE trial consisted of the prostate alone, and for the intermediate risk patients, the prostate plus proximal 1 centimeters of the seminal vesicle, right? So CTV for the low-risk patients consisted of prostate alone, but for the intermediate risk, the prostate plus 1 centimeters of seminal vesicles. If you answered that to any question regarding the CTV, you will not be wrong. and you can always quote the PACE trial. It is standard. So now we go a bit deeper, whether we are talking about CTV intermediate risk and high risk. So for the intermediate and the high risk disease, there are two CTVs you can be defining. The CTV PSV, that is the CTV proximal seminal vesicles, which is prostate with proximal 1 centimeters of seminal vesicles. And we'll just go back just a moment. Can I go back? How do I go back? Right. Wait a moment. I think what has happened is, yeah, cool. There we go.
Dr. Kamal, you are not audible. Hello.
Am I audible now? Am I audible now?
Yeah, now you are audible.
Okay, excellent. So there we go. This is where we are. So that's the pictorial representation. So CTV proximal seminal vesicle. So you have the prostate, and you can easily see how good I am at drawing. So that's why I have kind of taken this cartoon. But to just say that 1 centimeter isotropic expansion margin around the prostate, and that's going to give you your CTV PSV, right? Now, CTV SV, so nothing brilliant, but just prostate with 2 centimeter isotropic expansion. And again, even in the CTV SV, you're not including the distal seminal vesicles, all right? For low intermediate risks, CTV PSV, or which is proximal plus proximal 1 centimeter of SVs, is absolutely fine. And CTV SV is identical to the CTV PSV. So remember, some people forget that, some people think that prostate and seminal vesicle. No, P stands for proximal seminal vesicles. That's how I learned it a long time back, and that's what I'm sharing with you guys. Okay, now coming to the tricky bit. So far, so good for prostates, but seminal vesicles can be tricky. Well, they have been tricky for me. And the smart ones amongst you might be able to do that very easily, but I've had trouble with seminal vesicles, and so has a lot of my colleagues, both in England and the States. So here we are, easiest, the way I've tried to put this all down here, the way I would understand it, the easiest way I thought to contour the correct amount of SV is basically to include the target volume, is to contour the prostate first, expand by 1 or 2 centimeters, and then use this 1 and 2 centimeter ring structures as a guide for SV contouring. And you can otherwise just clip the SVs at these borders. But most of the times we also find that, yeah, most of the times things might be okay, but if the anatomy is unusual, if you're finding an unusual anatomy, then your method may not capture the whole of the SVs. So in that case, you can outline the proximal 1 centimeters and 2 centimeters of SV and CTV SV freehand using the anatomy of the planning images. And that has helped as well. And I believe that this should effectively cover the same length of the seminal vesicle from the point of insertion of the SV into the prostate. This is simply put, I would say first contour the prostate, then create 1 and 2 centimeter rings by isotropic expansion of the prostate. You may think, oh, what is grand about that? I think that the grand thing about that is that we have come to this conclusion after a lot of trials here and there. Okay, but if you follow this, first contour the prostate and then create 1 centimeter and 2 centimeter rings by isotropic expansion, you'll be good. So we'll come to real patient contouring. So the sagittal image here, and we are talking about the prostate. Then you expand by 1 centimeters. That is the cyan bit or the green bit. I mean, the Americans call things by weird names. This is green to me, or turquoise, whatever you call it. And then 2 centimeters is the yellow bit to create the isotropic rings. That's how in sagittals. That's how in axials. Similarly, taking on from there, so after contouring the whole of SV, the proximal 1 centimeters of SV is added to the prostate volume to form the CT-PSV. So as you can see, I'm repeating myself, but there's a purpose for this repetition because this will stay with you guys. And the SV at 1 to 2 centimeters is colored green, and the entire proximal 2 centimeters of SV is added to the prostate volume to form the CTV SV. So here we are looking at the proximal 1 centimeters here, which is in red, and the 1 to 2 centimeters in green. Again, oh, where is that gone? Why this thing? Right, don't go away. Right, cool. Right, so there we go. If you're having any problems with this, I would like particularly the juniors to have a look at this paper. I'll leave the slide for a few seconds so that you can make a note of that. This is from the Green Journal. We call it Radiotherapy and Oncology Journal, 127/2018. It is a Carl Salambert paper, one of the best in how to bring it all together. They have brought a full estro consensus guideline on the CT and MRI-based target volume delineation and primary radiotherapy for localized prostate cancer. So not just SBRT, for everything. It's a brilliant précis of what you need to do. And I have known centers which have taken this paper and formed their own guidelines out of that and are using it for their purposes. Coming to the organs at risk, right? Gentlemen and ladies, am I going all right? Should I continue in the same pace? Okay.
Yeah. Continue. Please continue.
All right. So, may I just check that if anybody has any questions and stuff, I'm very happy to take it either now or I'm very happy to take it at the end of the talk. I'll leave it to the organizers to determine how they want to do it. But yeah, I'm trying to keep it slow and slim. So let's see how we go. Yeah.
Question will be attained.
Okay. So we'll come to organs at risk. I call it OARs. And again, you might find that I'm stating the obvious, but I think in SBRT, the obvious must be stated. As I said, the stakes are big and we have a lot of high dose going in. So we need to be having absolute clarity about what are we doing. Again, everybody knows how a rectum is defined, but I define rectum for SBRT contouring like that. Solid structure, including lumen and the rectal wall. Again, this is important. Even senior colleagues have sometimes only marked the lumen and have not included the rectal wall, which is, I call sacrilege. We can't do that. We have to include the rectal wall in its totality. Now, extending from the anus to the rectosigmoid junction. Just that, the rectosigmoid junction from our anatomy times, I'm sure you all will agree, this thing changes. It is not stable. It is not just like at the same place for everybody. So we have to be very careful. Sometimes we take help of our consultant radiologist colleagues to help with marking. And I have no second thoughts about that. I just ask them for help because you need to be absolutely clear what you are marking. Then the way I see it is that it is denoted as where the rectum turns forward and laterally. I'm a simple man. That's how I understand that. Okay, so just to tell you that I've done some contouring as well, but here we come to the bladder. Again, in bladder, we are contouring the bladder wall as well as the lumen. So all of it. Urethra, if visible, again, I think to me, urethra is most visible in MR. I have colleagues who are brilliant in CT interpretations. They think that they can see the urethra a lot better in CT, but I disagree. I think it is better seen on MRs. And the prostate urethra is defined for the purpose of SBRT as the lumen on mucosal interface, extending from the bladder neck to the membranous urethra. Then penile bulb, another point of contention. Not everybody is in agreement. I remember in Christie, when we were planning prostates, um, you know, about 7 of the consultants, we were asked to do the same person's plan without telling each other. And one of the senior radiographers then assessed that plan. And I can tell you unashamedly, all of us drew different things. And all of us were right. So that is the kind of range which you've got in prostate planning. When 7 senior consultants are able to do different planning contours, you need to have some sort of a directive about planning guidelines. So here, penile bulb portion of the bulbospongiosum that lies inferior to the UGD, and the penile bulb is easily on a plan. Again, this is another MRI favorite for me. Femoral heads, these have to be outlined from their most cranial aspect to the bottom of the curvature of the femoral head. I exclude the femoral neck. So you don't have to bring the neck in it, just keep the head in it. There we go. So we can plan that. So organ source number 3. So bowels above rectum within 15 centimeters of the PTV. For CyberKnife, I would plan the bowels. You may say, oh, rectum is also bowels, so why are you separating rectum from bowels? No, here we mean the bowels which is non-rectum, so non-rectal bowels. Within 15 centimeters of the PTV for CyberKnife, and within 2 centimeters of the PTV for gantry-based SBRT or MRT. And you can mark that as bowel bag, because there's a lot of mesentery, and you can call it bowel bag. Again, for CyberKnife SBRT, I would bring in testes as well for organ at risk marking. Then the beam should not be allowed to traverse the testes. Please make sure, of course, these guys are not going to have babies again, but try to preserve the testes if you can, and due to the effects on the hormone production and subsequent confusion about biochemical outcomes. This is imperative because you know that testosterone determines the PSA levels to a significant degree, particularly in respondents. So if you mess up with the testes, you are messing up with the testosterone, and that's how you are messing up with the with your LHRH axis. So therefore, I think preservation of the testes is important. So you can mark that as a blocking structure. Okay. Anyway, there we go. So we swiftly move on to just a quick summary here that the CTV you can have as prostate with or without seminal vesicle, where you have the CTVP is the low risk, or the CTV PSV you do as intermediate risk. For SBRT, your CTV, I'm now bringing in the dose for the first time, that in clinical target volume, prostate plus minus SV, this receives about 40 gray, and this is referred to as the CTV proximal SV of 40 gray. And the planning target volume, which receives about 36.25 gray, is referred to as the PTV proximal seminal vesicle 3625 gray, and PTV SV of 3000. We'll come to that in the PTV considerations. Okay, so there is, now we've talked about the CTV, we're coming to the planning target volume. Again, there is a lot of variation in the existing studies regarding CTV to PTV margins. I can tell you, just you go from the West Coast to the East Coast in the States, or you go from the Christie to the Marsden in England, you will have variation. And that's why the PACE trial becomes a very significant uniformity creating tool. So I am mainly taking this stuff from the PACE trial because we have kind of legitimized that this is largely dependent on whether interfraction motion monitoring and correction is available. So you know that wherever your department is, your interfraction motion, how you are monitoring it, how is your corrections being applied, that is determining your PTV. Again, for the juniors, remember the definition of PTV. It has huge ramifications on your treatment plan, and of course your passing marks. Now, I would say commonly 5 millimeter margins in all directions have been applied, except for posteriorly, where the margins are reduced to 3 millimeters due to the proximity to the rectum. Now this bit, I showed you something called rectal spacer or rectal hydrogel. If you've got the hydrogel, you have the leverage of keeping this to 5 millimeters. But if you do not have the hydrogel, you will have to do that. So can you see how good is a hydrogel can be, where you can push the rectum behind? And no, I do not have any affiliations with the hydrogel making company. I do have no shares in that. I can tell you that. Now, next is the, oh, where is this gone? This gives me a bit of a heartache. Let me get it back on. Okay, again, that we want here. Okay, cool. All right. So, I've said here that 5 mm margins all directions except posteriorly. And then I was going to say within pace, the PTV is formed by applying 4 to 5 mm margin to the CTV, reduced to 3 to 5 mm posteriorly. So similar things. But I've mentioned about pace here is that how much we have incorporated the standard general practice in our format. So this bit, now this is for conventional plans. If you can see, I've dimmed this slide. I will not want you to focus a lot on that, but just to mention this was for the conventional plans. I'll switch to this one, the PTV margins for our SBRT. Again, I will emphasize that use fiducials if you can, if you have the expertise, if you have the confidence, and if you have the staff to do that. Remember, the margins may be slightly larger where fiducials are not used, and the range of permissible margins is defined below here. So you're talking about PTV-SV of 3000, where you are the CTV, you're doing the CTV-SV expansion by 5 mm, and then the PTV-PSV, you are doing for the PSV, that is 3625 gray, you're doing it by 3625 centigrade. So CTV PSV plus 5 mm or 3 mm posteriorly. Additionally, the CTV PSV, which is getting the 40 gray, you have a CTV PSV with no margin. I've now put down the permissible range. This is something, the key bit of this slide. So remember, CTV SV with 6 mm is permissible. You can go up till that length if the above convention is not used. And CTV PSV plus 4 to 5 mm, you can do that if this convention is not used. I do not think that if you use that, you will be in any way reprimanded for what you're doing, because that is something which is acceptable, and we have incorporated that in the PACE trial as well. Okay, now touching on the radiotherapy technique. Again, we in SBRT, we simultaneously treat multiple dose level PTB structures in a single phase. So you can think of SBRT as a type of IMRT, isn't it? Where you are doing everything in a single phase. Therefore, an IMRT or a VMAT planning technique must be used to obtain the prescription doses. There shouldn't be any doubt about that. Here I have brought, this is another key slide. We are talking about dose and fractionation. This is the standard dose and fractionation used in the PACE trial, and this is going to be the standard whenever SBRT is going to be formally approved by NHS England. So the dose for the SBRT arm will be 36.25 gray given in 5 fractions over 1 to 2 weeks. That is something which is going to be the British standard, and I think this is going to be followed at a lot of places internationally. 36.25 gray in 5 fractions over 1 to 2 weeks, whether you want a daily or alternate day. In our center, we are doing alternate day. It is just logistically more feasible. The prescription dose of 36.25 gray shall be the dose to PTV PSV, that is the 3625. This is something which is important for you to mention to your planning radiographers, so that they are helping you more and you are able to conform to the guidance. Again, so we have summarized just again PTV PSV. What does that include? So that includes prostate with proximal 1 centimeters of SV, and this is getting 36.25 gray. PTV-SV, which is 3000, which is proximal 2 centimeters SV, and this is getting about 30 gray. So again, for SBRT, there is an additional target volume we've talked about, and I've mentioned it before. That is CTV PSV of 40 gray, which receives which receives that amount, and this is the CTV PSV with no margin. Okay, when we talk about dose prescription, so now we are coming to the more technical nitty-gritty of prescribing. Again, here you I do not know how good are your terms with your physicists and the planning technologists. I think that's critical. If you have a very good working relationship with them, they can help you understand, and you both can mutually make the most of your skills and expertise set for your patients. Here, for SBRT, the prescription dose shall be 75 to 85% of Dmax, and aim is for the D98% to be more than equal to 34.5 gray or 34.4 gray. So that is radiobiologically determined. And that is something we should aim for. Again, if we describe the dose to the volumes, you have the PTV PSV of 36.25. Here in this, you are defining the volume, which should be getting more than 95%, and the D98 should be getting more than 34.4 gray. We've mentioned that, right? Again, the CTV and the PSV. So the same rules apply. In the CTV-P or PSV, a secondary dose of 40 gray should be delivered to the CTV-P or CTV-PSV, says that the CTV volume of 40 gray is more than equal to 90%. Again, whether your understanding is good or not regarding that, please make sure that you understand this and sit down with your plans, with your planning technologists or the senior physicists to ensure that you are achieving these guidances. Because if you are achieving these, then only you're going to have a good treatment plan, and that only will deliver it better. I've mentioned a note about the PTV 3000. Again, here it is going into more intricate detail. I would say try to focus more on the PTV 3625 and the CTV PSV. Make sure that this is definitely not compromised. So here, this is the first chart where I'm talking about dose constraints for organ at risk in a non-SBRT scenario. I will leave this on. This is perfect. I mean, you cannot have this chart as a smaller chart. You have to bring it all in. This has to be a busy slide, but I can't help it. So why am I putting this on? Mostly for the juniors, to just remind them about in a non-SBRT setting, because you certainly need to know all these values. It's available anywhere on the internet. You are now able to get the constraints from anywhere, but it is just to give you a reminder, and that is something which is more for the purpose of this talk. That is the dose constraints for the organs at risk in an SBRT setting. Here we start with the rectums. I've put it, one is a mandatory and one is optimal. So this is something which I advise my planning team to ensure that we are conforming to it. So for example, we are looking at the dose in this column. 36 gray, maximum volume should be irradiated with 36 gray is 2 cubic centimeters. And when we say mandatory, we do not have any exceptions. We have to adjust the plan if that constraint is not met. And as I said here, optimal is 1 cc. So the way I tell my planning team is that, guys, please make sure that your 36 gray is not exceeding 1 cubic centimeters of my plan. And in exceptions, they go between 1 to 2 centimeters, cubic centimeters, and I never accept anything more than 2 cubic centimeters. Then it has to be a replan or stuff like that. Similarly, bladder. So I'm not trying to teach you how to read a table. I'm just highlighting this, that how I look at this table how I review things. I go back to basics, man. I would always make sure that in radiotherapy, I think we all read Hall, and it said somewhere as low as reasonably achievable, a Lara principle, isn't it? And I think that has always stuck in my mind. So, and time, dose, distance philosophy. So as low as possible to any organs at risk is my aim. So if you can save toxicity, that's the idea of stereotactic body radiotherapy. You're saving on time and you're saving on toxicity if you can. So bladder, for example, 37 gray, ideally it should not exceed 5 cubic centimeters of volume. Mandatorily, it must not exceed 10 cubic centimeters of the volume. We come to femoral heads. Again, 5 centimeters is 5%. Is fine, because you know that there's a possibility of osteoarterial necrosis and all that stuff. Then, if we look at the bowels, 30 gray to the bowels, only to 1 cc is mandatory. Now, this is pretty tight, isn't it? But then that's the beauty of SBRT planning. If you are doing all that cyber knife and blah, blah, blah stuff, and you cannot conform to your bowel constraints to that degree, then there's no point. Because if you are giving this chap fistula and stuff, I don't think he's going to thank you. He ain't thanking you at all. And you are not going to sleep well either. So urethra, again, if visualized, I've said there, I've put some figures there, like 50% for both penile bulb and urethra and testicular. You are blocking that anyway. All right. So then coming to the initial and on-treatment checks. So we do the cone beam CTs for the anatomy check. That is the initial setup. You can see in the various panels, left and right, you're seeing that how the cone beam CT images and the superimposition is able to give you the match. That is the bony match, the soft tissue match, and all the sorts of matches you can think about. Then you have the KV setup, that is the kilovoltage MV paired marker match. We believe that this the KV MV paired marker match is pretty good. It sounds very old style, but it has been very good for us. So you can see the fiducials as well there, and this is both for initial setup and during treatment. So again, a lot of radiographers, if you've got a good radiographer team, and if you've got good liaison with them, if you're constantly going to them and seeing what is happening, what they do, you will get a lot of benefit in that. Again, for the benefit of the juniors who are listening to this talk, I have in my training period, I've always gone to treatment machine setups. We always went there and just had a look around what our radiographers are doing, how they are matching things, how they are setting the patient up, what are the problems they are experiencing. And when you go there, all the books and all the knowledge of the books, you see how it is practically coming to help. Anyway, we move to follow-ups. So again, you've done all that, you've done the checks, you've delivered the dose, and now you want to have just a very quick note about follow-ups. I think that the biochemical control is comparable in terms of long-term follow-up. When I say biochemical control, I mean the PSA-based follow-up. And this is necessary to confirm. Oh dear, this is where is that gone? So we are coming to. Sorry guys, this my computer is very touchy. Right. So again, make sure that you're assessing toxicity in your follow-ups, particularly the genitourinary, the gastrointestinal toxicity, and sexual function, essentially. Now, again, it depends how you are measuring the toxicities in your center. I believe that you form any kind of a uniform pattern to assess toxicity. Like you can borrow the long-term toxicity assessment tools of any center and just do that. you should make note of your toxicities for these patients. Remember, these guys are going to live long. These guys are not dying soon. Well, that's not the intention. Um, and you will want to know how much your SBRT is going to be comparatively better in terms of long-term and short-term toxicities from all these perspectives. And if you do not have mechanisms to record toxicity, I don't think you will have mechanisms to compare in the future. So that's my recommendation. It is imperative that we have a very good mechanism of recording toxicities, and this is something which is going to be coming big in the international arena soon. So a lot of people who are going to do the work in this, you'll get published, man, because this is happening. This is coming big time. I would say that in the follow-up pattern, try to assess your patients for acute toxicity within the first 3 months. A lot of people leave these chaps for longer. I think that is not right. I believe that the first 8 to 12 weeks are very critical. You want to know what is happening, particularly with acute toxicity, and you need to find out from these patients. I understand that sometimes the follow-ups is difficult, but I think in India our people are getting very switched on now. If you tell them, they will follow. Then every 3 months for the first 2 years, and then every 6 months for the 5 years, and annually until year 10. People may disagree with this, but that's what I practice. I would practice. Of course, we are not into the 5-year or 10-year time mark with the SBRT, but we are doing pretty okay with the initial time points. Again, toxicity recording, it depends what criteria you want to use. I would recommend RTOG or CTC version 4. I would recommend both. Just you can use that link. On Google, if you just put CTEP cancer.gov, and RTOG or CTC version 4 criteria, you'll get that. Then I think this is coming big time. Patient reported outcomes, or as we call PROMs. PROMs monitoring. You have many scores in that. Again, this is, I think this Mac is crazy. Anyway, we will. All right. Yeah. So you have various, we follow the IPSS, International, Prostate Symptom Score, or you can follow the VASI score, EPIC 26. There are loads of, tools out there. And can I really conclude this talk? I don't know, but you have to put in a slide of a conclusion. So I'll just put it in there. I think this is SBRT is faster, cheaper, and better way of treating prostate cancers. Only if we are able to be very clear that we can have the full expertise, full checks, and full quality assurance for SBRT. Make no mistake that if you miss out on the quality assurance side of things, you are going to miss out on your treatment outcomes. So quality assurance is extremely, extremely important. When we look at, damn it, this is right, just not right. So I think this is an evolution for external beam radiotherapy anyway. And I believe that this is an acceptable option for the low and intermediate risk patients. So again, that is the indication. At the moment, SBRT cannot be recommended for radical treatments of high risk localized prostate cancer. I think this is only indicated right now for low and intermediate risk patients. When we make the most of that, I think once we have done that, we should be able to expand on its indications. Late residual toxicity is minimal with hyperfractionated RT, including SBRT. Again, that has been further minimized with the use of spacer hydrogel. And we have seen that urinary toxicity may be more pronounced early. but it's usually self-limited. Again, you will not know about that if your follow-up is not robust. So make sure that your follow-up is very good. I would reiterate that whilst SBRT is coming big time for prostate cancer patients and it is a quicker way, make sure that you've got everything in place you need to have to ensure that the dose delivery is brilliant and the delineation is perfect and your your planning is literally top of the end. Okay, thank you very much for your attention. I think without these centers where I have been, I could not have made this talk. So I think Christy, MD Anderson, Genesis Care, Milton Keynes, and Northampton General Hospital, and of course the PACE trial group at Marsden and Mount Vernon. Most importantly, we are all here because of our patients. So that's where I think I should stop blabbering.
Yeah, thank you, Dr. Kamal, for a very informative and interesting presentation. Most of question about prostate SBRT is start from the simulation and indication when to do SBRT, when to select which case to be selected for SBRT and which case to be selected for hypofractionated RT. And the another controversy is whether nodal positivity is a contraindication for SBRT or that also can be treated with the SBRT. So, Dr. Sunil Chaudhary, hello, Dr. Sunil. I think he is not present. Then
Tarun, you can continue.
Okay. Thank you, ma'am. So we will take the question first posted by participants. Then we'll discuss my question also. So first question is rectal contouring. Is you already told, but since it's asked, you can reiterate with that whether rectal contouring is start from anal verge or from anorectal junction.
Okay, so is my screen still visible?
Yeah, it's still visible.
So I've brought in that slide, and I was expecting that question. So thank you guys for listening. I think I'm glad that people are listening. Again, I will reiterate. We are talking about rectum as a solid structure, including the rectum and the electron wall and the lumen, extending from the anus to the rectus. Now, anus, your question is whether, if you can rephrase that. So what are they saying? Where is the extent of anus should we consider, is it?
Yeah, whether we start from an anal verge or from anorectal junction. So anal canal also is part of rectum. In
I would say anal verge.
Yeah, it is anal. We should start from anal verge to rectosigmoid junction as a solid structure.
Correct, because the reason for that is that it's always good to overshoot in terms of organ death risk. If you are overshooting, you are more likely to be safer.
Yeah. So next question is whether what bowel protocol you following and whether you using oral contrast or and rectal enema, and if yes, then how you follow that. You can explain the procedure.
Okay, so we are not using enemas, we are using oral contrast.
Okay.
And that has helped us, and with a combination of MRI and CT with oral contrast, I'm sure you will get a very good bowel delineation and bowel description.
Okay, right. So, but most of trials they recommending and in guidelines rectal enema before about 2 to 3 hours before simulation and before treatment.
Okay, so you may remember when I mentioned, where is that? Just a second, let me bring it in. Yeah, so you may remember when I said in here in the patient prep and positioning, I said that every center has the right to do their own bowel prep. If your center finds that rectum enemas are helpful, go for it. Nowhere in any international paper or in any guidelines, it is said that rectum enema is contraindicated. No, the way you want to prepare your bowels is absolutely your prerogative and you can do that. I would say, yes, if enema is working for you guys, go for it. For us, oral contrast and CT and MRI has been helpful. But if, for example, if they are not, if some patients have lethargic bowels, if I can say that in a decent way, yes, even rarely we've had to use rectal enemas.
Yeah, right. So, and another very uh, controversial area is the urethral contouring, whether it is to be completely avoided or we have to cover with some dose of radiation, and how to contour urethra.
Okay,
Whether
so
we use only few millimeter of urethral lumen, or we give some margin.
okay, so I've brought back my slide, slide 36, in the ORR 2, so urethra. Again,
Yeah.
you will need an MR. Ideally, I need an MR, and I would contour the prostatic urethra, and we define that as a lumen or the mucosal interface, extending from the neck to the membranous urethra. Uh, I would say that go for margin. How much of
Okay.
a margin you go for? Let's say you've done a rough urethral contour. Do you go for any margins? 1 millimeter, 2 millimeters?
Yeah. So,
We
I
usually
think 1 millimeter yeah, from the lumen, 1 to 2 millimeter. Yeah.
Yeah, 1 to 2 millimeters is safe. Don't go
Yeah.
beyond 2 millimeters.
Yeah.
I'm not in favor of going beyond 2 millimeters. In 2 millimeters, you will be able to cover all of the urethra. Because if you go beyond that, I think that's not much of urethra. That's much of our will and wish.
And now I think one thing is less covered. That's why the question is related to that. Uh, what are the criteria for selection of patient for SBRT in localized prostate? Is every patient to be taken for SBRT, or there is some criteria based on IPSS score or volume or in median lobe hypertrophy? There are a lot of questions in mind. How to select right patient for SBRT?
Okay, so I'm glad that because I do brachytherapy as well, I might be able to answer that question to a bit more confidence. See, whenever we do like HDR prostate brachytherapy, we know that. Let me just bring this thing up. Where is that? Okay, I'll bring the slide here. So,
Yeah.
um, it, where, before I touch upon that, so in brachytherapy, you know that let's say if you've had there are absolute contraindications and there are relative contraindications. Let's say your chap has had TURP, that's a relative contraindication for brachy. If your chap has a prostate volume of more than 120 centimeter cube, you try to avoid HDR brachy, right? Then if you have the pubic arch interference, you try to avoid HDR brachytherapy. None of that is a contraindication for SBRT. Whether prostate size, whether there is pubic arch interference, whether there is whether there's a history of TURP or not, I don't think that's in any way a contraindication for SBRT. So that's the beauty of SBRT. We can do SBRT for people with any of these limitations. We can use SBRT for people who have had other problems as well, because you are using multiple beams, and your dose delivery can be extremely good. Now, coming to your question about that in what risk categorization, if you look in any of these papers, and including when the PACE trial and further reviews of that comes up, except for these two, the CATS trial and the CANG trial, nobody has included any high-risk patients, okay? And again, when we talk about high risk, we are talking about, because high risk is in multiple categories. I would still very strongly recommend stick to low and intermediate risk groups only for SABR or SBRT. You are more likely to be assured of a very good outcome. The moment it becomes high risk, you are talking about, you are risking micrometastatic disease, which has not been addressed. You are risking, areas which require treatment, which you have not treated with SABR. Coming swiftly to your question about nodes, I don't recommend SABR for nodes at the moment. I mean, you do not have that kind of a array of studies to recommend that. Yes, you can. People can do anything they want, but it is not evidence-based. I wouldn't touch in there. I wouldn't go in there for nodes. I would just stick to low and intermediate risk groups. If you're so keen that, oh, there is a high risk chap, I would stick to T3A, Gleason 8, and PSA less than 20. So very, very, but again, that is also not recommendable. I would go by evidence base and stick to intermediate risks. Do not use SABR for nodal disease at the moment. I'm not ruling out its usage later. It will happen, I think. But let us, as I said, let's walk first, and then we will run.
Yeah, right.
Yeah, Dr. Kamal.
Yes.
For how much time will you wait after TURP?
I would wait for, okay, I would wait for about minimum 4 weeks.
Okay, and do you consider that if the patient is having UTI, and we usually in our practice do IPSS score, and if it is bad, then we don't go for hypofractionation.
Okay.
That you know, depends
Okay.
upon frequency, urgency.
Okay, I think again, this is also I think I've touched about. So coming to the question about UTIs, look, you and I both know that SBRT is not an emergency treatment, isn't it? It's not an emergency treatment.
Agree.
Right? When these guys can wait for months, many months, even sometimes years, why not we rule out UTI completely,
Okay.
right? Go full on for treatment. Yes, when they have UTI during SBRT, I will complete it with antibiotics. But if you've had UTI before, I think deal with it first and then go for it. That would be my approach.
And any type of scoring you don't consider?
IPSS, stick to IPSS.
Okay.
Yeah.
Dr. Arun, continue.
Yeah. So, as you told, there are questions if complete seminal vesicle involvement is there, then you can consider SBRT, or only the proximal seminal vesicle involvement is an indication for SBRT.
Only proximal. So
only
if you
proximal.
see here, if you see the moment your seminal vesicle involvement is complete,
yeah,
your cancer is in T3B group.
Yeah.
It becomes a very high risk. I would exclude that guy.
Yeah. But there are trials, some data is from India also. There is a study from Tata Memorial, TMC, Kolkata, where they also done in high risk cases with with addition of hormonal therapy.
Yes.
But yeah, it is a few study, and I think in UCLA study also they use some did SBRT in the some high risk cases.
Yes.
So
So I'll
yeah,
talk to you about the UCLA paper. So they
yeah,
did do high risk cases as well in
yeah,
UCLA, but they were themselves confused how to interpret the results,
yeah,
whether they were hormonal effects or whether that was SBRT. So you have an amalgamated outcome where you do not know whether SBRT was good or your hormone therapy was good.
yeah,
So as
right,
I said, yes, yes, you can do that, but you will not be able to you will not be able to differentiate what has worked and what hasn't. Yes, people can do it, and in the private sector, a lot of people are doing a lot of things. I would say if you want to stay away from litigation, don't do it.
right. And whether, as you mentioned, alternate day treatment, there are some studies they are also done on weekly basis. So, what is uh, your interpretation in that case? Whether it should be alternate day or it can be done daily basis or weekly? Is any decline in biochemical control with extension of total duration of treatment?
Okay. So if we go by, so I think you're very beautifully brought radiobiology in it.
Yeah.
Let us start by discussing, do you think duration of treatment is very important in prostate cancer with its alpha beta ratio?
I I think no. Duration of treatment. That's why they in most of trial where they did weekly basis, the biochemical control is similar.
Yes. So
Yeah.
I don't think that the duration of treatment is very, very particularly important in this. However, we have to understand that not only the prostate moves, we have to also understand that the more you extend the duration of treatment, the more quality assurance you will have to do in SBRT, right? If a chap comes 1 week after, and if a chap comes just the next day, you are more likely to reproduce the things better if he comes next day, right? So whilst I don't see a radiobiological disadvantage in a protracted treatment, but I would, as I've said in this slide, in England we have stuck to either daily or alternative day things and finish it off within 1 to 2 weeks, and that is very logistically feasible. Biochemical survival will be the same, but then, as you can imagine, uh, both in some of the low risk patients, no treatment versus active treatment versus surgery versus SBRT all have the same outcomes.
Yeah. Right.
So I think the way I will look at the big picture, I like to get these guys in and out as quickly as possible, and giving the same outcomes.
Yeah. As you mentioned about rectal separator or space OR, yeah, hydrogel OR,
Yes.
hydrogel spacer. When you do before simulation, whether you do 1 to 2 days before or week before, and how many days it stay? Is it stays for total duration of time or it is stays for month? Um, is any variation of volume of that space OR over time?
Okay. So spacer, it is my practice to do the spacer at least 1 week before. And when I say 1 week, I mean 7+ days before the planning scans. Do not do that within a week. It's an intervention. Your planning scans will have artifacts, so don't do that. Do it just more than it has to be more than a week before. So that's from that perspective. It stays there for 3 to 6 months. It auto dissolves. It is a self-absorbed, and in 3 to 4 months, 3 to 6 months time, it auto dissolves completely. And sorry, what was your last question in that respect?
Yeah, what is decay time of that space
Yeah,
OR?
as I said, 3 to 6 months. It goes all over. It gets self-absorbed.
Yeah, is any side effect related to that space OR?
Not at all. Very, very infrequent side effects. It is very easily tolerable. It is biocompatible liquid gel,
Yeah.
and there is no reaction. Yeah, it is done under general anesthesia, sometimes under local anesthesia as well. So all the GA or LA related adverse effects, etc., are to be considered.
Yeah. You did not touch about balloon immobilization.
Yeah, because
Is that
balloon breaks, balloon
outdated
breaks,
now?
balloon
Yeah.
breaks, and it's a mess. That's why I
Okay.
didn't touch it there.
Yeah.
I would not recommend balloons.
Yeah.
Stick with
Yeah.
the spacer. It is biocompatible. Even if it leaks, it's not going to cause you any problems.
Yeah. Right. So you emphasized the use of fiducial. There are a lot of uh, question about those who are not practicing no, fiducial. So what are message for that? Whether they start using fiducial or they can continue with CBCT, IGRT based practice.
They can, if they are
Yeah.
very sure about their anatomy, if they are
Yeah.
very good about their expertise, and if they've got very good liaison with the radiologists and the radiographers, the planning dosimetrists. As I've said here, if they are using MR guided radiotherapy, fiducials are not mandatory anyway. So they can, I think the British data will back that up. So they don't need to worry about it. If they're sticking to CT base, then I've said that try to be as clear as possible.
Yeah. Because there is a group of practitioner which those using transperineal clarity system.
Mm-hmm.
They think there is a they very easily able to manage getting with the transperineal ultrasound, which is the Electa system,
Yeah,
and
that's
they
fine.
don't think a fiducial is going to help much with that.
I again, fiducials is a very interesting topic. It's a complete different lecture, I think. But
Yeah.
yeah, but yes, you see, these are all expertise dependent and very individualized things. I would say doing a bad fiducial insertion is much worse than not doing a fiducial insertion, right? So only insert if you are good at it, and if you guys and whosoever is doing it is very clear what they are doing, what we are trying to achieve, and there is a good liaison, there is a good multidisciplinary team approach in that. If the inserter is in any doubt, or if there is any kind of a lack of confidence, any of us can have lack of confidence, don't do it. Go to MR Linux, use the MR guided approach. You don't need fiducials. They're not mandatory in MR Linux approach.
Dr. Kamal,
Yeah.
in your setup, who is putting fiducials? Interventional radiologist?
No, we have managed to bully our urologist for it.
Okay. And what do you suggest them? How to put them? Do you say anything? Yeah.
No. I just tell them, I just basically give them our guidance that this is how we need it to be done. Can you put these markers? They put it. I trust them. They do it well, and that's not a problem. I would only guide them if they have messed it up. So if sometimes they have not been able to, when the prostate, for example, is very, very rigid. Sometimes we have an extremely rigid prostate with a lot of fibrosis and things. Then that's a pain. But we always have to give in to get some. I think it's been very rare, but they have managed to do fiducials very easily, relatively.
Okay, thank you. Dr. Arun, continue.
Yeah. The next question is the should neurovascular bundle to be included in target volume if not involved?
Right. If you can delineate the neurovascular bundle, include it.
Yeah, it is very difficult to identify and delineate neurovascular.
Correct. And
Yeah,
you'll find 10 senior radiation oncologists delineating completely different stuff
yeah,
for
yeah,
neurovascular bundle.
yeah.
So I would just stick by the margins I've said, and that will include the neurovascular bundle. See, there's no doubt that these
Yeah.
chaps will
Uh,
have erectile dysfunction for a variable period of time. But then I always tell them, if you've not had babies, don't have treatment.
since you mentioned about brachytherapy, if you have both option, then how you decide which patient to be taken for brachytherapy, which patient to be taken for SBRT?
Very simple. At the moment, NHS England has not brought SBRT in a publicly funded domain. So whosoever pays for the SBRT or is insured gets SBRT. However, if the chap can pay and asks me, what will I choose for him? I would tell him maybe go for non-interventional approach. Uh, Again, this is dependent upon what kind of comorbidities this chap has. Can he sustain a general anesthesia? For example, if they have intermediate risk disease, I'm doing brachytherapy in 2 sessions. So I'm giving 26 gray, that is 13 gray each per sitting. And with all this stupid coronavirus going on, you have to give about 2 to 3 weeks of a gap between the 2 fractions.
Yeah, right.
So it's a nightmare. Anyway, so I tell it all to them and they choose. In England, most of the times they choose and they tell you what they want. You don't have to choose.
Yeah, yeah, right, right. So again, the question about the prostate volume. If prostate volume is high, can you use hormonal therapy and reduce the size and then do SBRT?
Yes, you can.
It's you.
Yes, you
Okay.
can.
Yeah.
But again, this is a very evidence lacking domain. I would always say to people that follow the hormone therapy policy for intermediate risk cancers, where we give 6 months of hormone treatment. If an individual clinician decides to give 6 months of hormone treatment for their intermediate risk chaps, I will have no objections.
Yeah. Is there any ideal prostate volume or any cutoff of volume where we can think for not doing SBRT?
No, I think I've been fortunate, touch wood, that I've never had that experience. I mean, I've not had like a 250 gram prostate. So but I don't think there's a cutoff, but eh, nobody knows. I would stick. On an average, I have no issues in treating even higher volumes with SBRT.
Um,
Right. I think somebody's audio is not muted.
yeah, some there
But
is
no
some
worries.
audio. Yeah,
Dr. Arun, you continue. I am.
yeah.
I am.
I think there are a lot of questions, but we can't go for. It is 1.5 hours. Can we proceed for further question, or we should stop?
Maybe
Dr.
maybe we can take 1 or 2 final questions.
Yeah. So, for fiducial, you told 3 fiducials. So, can you tell about the location of fiducials? Are we 3 fiducial are essential, or we can go with the 2 fiducial, one in the left lobe and one in right lobe?
Do 3 if you can.
Yeah, we can go with the 2, 3.
Yes, go for 3.
Yeah. most of people are not want fiducial. Both patient and doctor try to avoid fiducial placement and they want to go ahead with the IGRT. So should what type of care you recommend in this type of practice where we don't use fiducial?
Use MR guided radiotherapy.
Yeah. Okay, I think we should stop now. Dr. Anu?
Yes, Dr. Arun, I'm here.
Yeah. I want to invite you. Now you can give a closing remark and thanks to Dr. Kamal. There are a lot of people have already posted a very nice interactive session and thank Dr. Kamal. Over to Dr. Anu.
Thank you, Dr. Kamal, for your very, very nice presentation. It was a great effort. And on this, on Sunday, on your call day, you still take time. So we all are very grateful. And I see Dr. Daulat Singh is here. He's our senior, both Kamal and, he's senior to both of us.
Oh, yes.
Dr. Kamal, can you unmute yourself? Dr. Daulat, sir, please unmute yourself.
Hello, good evening.
Hello, Dr. Singh.
Hello. Good evening, Dr. Kamal, Anu. How are you?
We are good.
It's a nice presentation. Yeah, I joined late, but it was
No
nice
worries.
presentation and very informative.
Kamal, I think we can do one more thing. There are lots of questions. Still, people are posting questions. So I want you to write your email in the chat box, and whoever wants to interact with you separately, and if they want to ask you something, you can answer them in, reply to their emails if you have time.
Yeah, that's fine. I think what is important is that people have the clearer are the questions, the better are the answers. I think courtesy Dr. Verma, I have answered a lot of questions. I'm pretty sure if people go through this presentation, they'll have a lot of things. But yes, I can take. You can redirect the questions to my email when you get it, Dr. Anu. No problems.
Okay, Dr. Arun, can you manage that?
Yeah. I
Just
can
email those questions to him. He will answer them.
Okay, thank you.
It will be good to select the questions, the ones which you can answer.
Already answered. They should
yeah.
not be repeated again and again. But there are few questions left.
Yeah. We'll manage that. Okay.
Yeah.
Okay.
Okay.